Hi everyone, I'm Dr. Faisel Syed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel Friends, where we believe access to primary care is a right, not a privilege. Today, we're talking to Dr. Elliott Fisher from the Dartmouth Institute and the Institute for Healthcare Improvement about leaving the healthcare system better than we found it. Let's dive right in. Hey Dr. Dan, how's it going?
Good. How are you, Faisel?
I'm doing really well. Really excited to welcome Dr. Elliott Fisher. Dr. Fisher, welcome.
Hey, cool to be with you guys.
Dr. Fisher, I'd like to get right into it. I mean, one of the common questions I love to ask everyone, especially for the students who are listening, is, we know what you've done and where you're at in your life now, but what was it that attracted you to medicine in the first place?
Oh, it's a fun question. Everyone should think about and look back at it. So I hadn't really thought much about medicine. My father was a prominent lawyer, law professor, um, and I really didn't know what I was going to do with my life all the way through college. I majored in Chinese with a minor in mountaineering, which really wasn't a minor. Um, but then after graduating, unsure what I would do with my life, I decided to drive an ambulance in Somerville, Massachusetts, which was right next to Cambridge, where I grew up. Except that while Cambridge was a rich and wealthy place for most people, Somerville was one of the poorest cities in Massachusetts at the time. And the people I was taking to the hospital, the kids I was seeing, and I was a kid, had diseases that my classmates had never experienced and were dying of them. And it was also obvious that the quality of care in the hospitals in Somerville was, to say the least, no good. Often what many people now experience. Anyway, so it was fun driving an ambulance because you get to pretend that you're saving lives when really it's just the human organism being very resilient and surviving whatever we do to it while it gets to the hospital. But so I thought clinical care might be fun, but I also really wanted to get involved in trying to figure out what is it that makes performance of the American healthcare system so awful in some places and so great in others.
Yeah.
Um, and so I decided I'd go to medical school with a strong interest in health policy, and ended up, you know, fulfilling my dreams of being, both a doctor and engaged in health policy. And so, I feel like I've, been incredibly blessed and lucky.
So many doctors, and especially even now we're meeting with residents, talk about the systems and the problems in the systems, and if we could only do this, then that. But it really never really gets out of the hospital or the doctor's lounge if you're lucky. There's like a griping session that happens, and then they're kind of like, it is what it is, and they carry on their regular lives, their regular day-to-day lives. But what was it with you that you took it that next step further to actually becoming effective and taking actions to start making those pushes? How did that start off for you as a doctor?
Well, it started long before I was a doctor. I mentioned my prominent father. Well, he woke up in the morning, looked at the headlines in the newspaper, and said, I got to fix this. So, I mean, he had come back from World War II, having lost all of his roommates to the conflict, and having flown over Japan in a weather observing bomber. Came back convinced that this is not the way to solve conflict, and then devoted the rest of his life to figuring out how to reduce the risk of conflict. So he founded the Harvard Negotiation Project. Anyway, my brother and I grew up, with a very strong sense that our mission in life was to make the world a better place. Actually, we knew that. And our mother was the same way. She was involved in Planned Parenthood in the 1950s.
Awesome.
So we both grew up with that obligation, with that sense of obligation, but it was not knowing how to do it that was so uncomfortable. I think the thing that made it possible, while a student, and then while a resident, and then later, was having friends colleagues who we all decided we would work together to try to do something about this.
Wow.
We founded a medical school newspaper. I joined the Public Health Coalition while a resident. And I don't think I would have done it by myself, but I think it was the fun of working with other people committed to trying to make a difference, and then realizing that you could. That the positive feedback came from you know the medical school deciding that, oh well, they'll pay more attention in the minority admissions committee to admitting a more diverse student body, or uh, and there were some windmills that we fought. We thought no one should take stethoscopes from the drug companies, and we were soon labeled the granola lunch punch. But other than that, um, it was we had it was I feel like I'm very lucky.
Wow. So you had this like you had the heart of an activist early on, and then as you were making gains and you were connecting with other activists, other passionate people, and you were making gains, that positive reinforcement helped carry things forward.
Yeah, I think that's right. At every and being willing to ask for help, being willing to make a phone call that may be difficult to make. I was a fellow at the University of Washington, and this Bill Richardson, who was the provost of the university, way 100 layers above me, um, was appointed to run a committee on how to how to deal with uncompensated care, the hospitals that are taking care of
Yes.
lots
Yeah.
of poor people, and the cost of that. And I just called him up and said, Mr. Richardson, could you use some help? And he could have said no, but he said, sure. So, I helped write a report that led to, and the positive feedback from people saying, sure, we'd love your help. Yes, you're going to be a grunt for me for a while or with me, but, I got to write the draft of the report.
Yeah.
So I'd encourage anyone who has this sense of frustration with the way things are to think about, well, who do I know or who could I reach out to offer to help with an important problem? And it's got to be close to your heart, so it should be something you care about. Um, but then find out who else cares about it and whether they could use some help.
I love that advice that you're giving because we're out on the road meeting with residents, internal medicine, family medicine residents. We meet the geriatric fellows, and we're trying to open their minds to think outside of the transactional mindset. High fiving a patient, you get paid. Just but anything, whatever it is to put a code on it, you get paid. To actually going from that mindset of being prescriptive with all the evidence-based guidelines to actually being more influential and being feeling much more fulfilled and effective through being influential. And the feedback that we get is one of two sort of situations you fall into when you say, well, there you can practice in a way where you can be focused on being influential. They say, well, that sounds too good to be true, or it's too hard to be done. And as soon as you mention anything about value-based care, anything about any type of risk agreements, right? Well, that existed back in the 80s and 90s. There were thoughts, and that never worked back then. And we sort of get lumped into both. When you
Uh
start
huh.
talking about these newer models, you get lumped into a lot of the bad actors or the bad situations from the past. And so you were quite influential with creating a lot of the concepts that really have taken off, even that we see in the world today. What was that world like? People ask us about that time. RVUs are being created. This concept of managed care, this concept, all these concepts of people coming together, focusing more on being effective with outcomes, to where we are now today.
Oh, that's a big and complicated
Sorry,
question.
sorry, didn't mean to do it, but
So no, no, I
it's
let me
sort of
let
top of
me
mind right now when we.
well, let me see if I can tell a little bit of the story of the transition as I experienced it. Um, you know, and this is ancient history to the most of the students and residents, but there was the early world was a purely fee for service world. Hospitals were paid on fee for service, docs were paid on fee for service, and then there was a recognition that um, this was driving higher costs.